Hi, and welcome to this week's episode of Ask Dr. Jessica. I'm so excited to have back Dr. Katie Marks-Cogan. We're going to do a part 2 on allergies. Dr. Katie Marks-Cogan is an allergist for both adults and for children. She has her own private practice in Downtown Culver City called Clear Allergy. Welcome back, Dr. Katie.
Thanks, Jessica. It's fun to be here with you.
Katie, tell me really quickly, how many kids do you have? How old are they? Just to let the audience know a little bit about yourself.
Oh, yeah, of course. I have two little ones. My son is 6.5, and my daughter is 3.5, which is very weird to say because I still think that she's just a little baby. But it's been going fast, and it's wonderful. They keep me on my toes, as I'm sure your three do.
They definitely keep me on my toes, but it's good. I feel like they also keep us out of trouble, right?
Yes, true. What would we do with all that time?
All right, so Dr. Katie Marks-Cogan, I wanted to ask you, last time you were on, we talked about food allergies. I wanted to talk also about something that's really common for a lot of us, and that is environmental allergies. I know they're very prevalent, and a lot of families don't know quite how to improve their symptoms. Can you talk a little bit about environmental allergies, like what to look for? Let's start maybe with.
Sure, absolutely. So when we talk about environmental allergies, basically we mean allergens that can get airborne, right? Get into the air and cause symptoms. And so when you say what to look for, they can cause symptoms of allergic rhinitis, or, a lot of people know it as hay fever. And it's when...
Sorry, can you say what is allergic rhinitis?
Yeah.
What does it look like?
It looks like sneezy, runny, stuffy nose, red, itchy, watery eyes, postnasal drip, which in kids a lot of times causes like a chronic throat clearing, sometimes a chronic cough. And, this is quite common and can really manifest and look different in many different children. But generally speaking, babies or children less than like 2 years of age, they really don't have environmental or seasonal allergies. So seasonal means allergies to pollen. And when I say pollen, it means grass, trees, or weeds, right? All of those can produce pollen that gets into the air and causes symptoms. So generally, young children don't have pollen allergies. They can be allergic to some indoor allergens like pets, cats, dogs, dust mites, mold spores. And then as they get older, obviously they can develop seasonal allergies. So that's allergic rhinitis. Environmental allergies can also cause asthma, right? So allergic asthma, and asthma is a disease where someone has difficulty breathing. They can have trouble taking a deep breath. They could present and just have a chronic cough, right? Cough variant asthma. They might have trouble exerting themselves or exercising. So again, multiple different ways to present with asthma, but environmental allergies can cause that as well. It can cause skin issues. So many different things.
Now, okay, I want to bring back this point you were saying how in the first under 2 years of age, it's not very common to have environmental allergies. So I want to touch on this because so many families, their children will have multiple colds or they'll have runny nose that they'll see last for a few weeks, and they're worried that it's allergies and they'll try Claritin. But what I've read is that because it takes a couple of seasons for kids to develop environmental allergies, it's not likely. So would you agree, like if I see a kid that's 18 months old and has had a runny nose for a while, how likely is it that it's really environmental allergies?
Yeah, no, you're absolutely correct. It is unlikely. The kiddos with eczema are probably more likely to develop those indoor allergies. And, any child can develop those indoor, but again, it's usually not until closer to 2 years of age. And for pollen, for seasonal, I think if you see an 18-month-old and they have a runny nose for a year, maybe because they're in daycare or they're around siblings, I say,
Right.
Good.
Right.
Let your immune system see the germs. You want germs, right? You want
Right.
colds early on. It helps mold your immune system. It teaches your immune system what to do.
Right.
So Good
Run
for
around
them.
in dirt, get dirty, get
Get
around
dirty,
those kids.
get snotty. Go do it.
All right. So, and I mentioned this because it's so common for me to see kids with those daycare colds, back-to-back colds, and I just wanted to make that point to families that it's probably not environmental allergies. It's likely just that those daycare colds, right?
Exactly. And that's why a lot of
Yes.
times when they try Claritin, it doesn't work because Claritin is an antihistamine and the symptoms are not from histamine being released, right? Because it's not from allergies. And so, sometimes maybe they'll dry it up a little bit, but generally they don't really help. It's because it's not allergies.
Right. Great
Yeah.
point. I love it.
Yeah.
Okay, so now let's say we have an older child where they have been having, itchy, watery eyes, runny nose, and we think that it's probably an environmental allergy. How necessary is it for these families to see an allergist? I mean, is it okay for them on their own to try other methods or, because a lot of times I'll tell families, we'll send them to an allergist and they'll come back with all due respect, I'll send them to an allergist and it'll come back saying allergic to oaks. And I live here by a city called Thousand Oaks. It's really impossible for kids to avoid oaks. And then we're sort of back doing just the basic preventative measures anyways. Like when do you think a kid with environmental allergies really needs to see an allergist?
Yeah, such a good question. So, let's see, how am I going to start with this one? So, I think it's very beneficial for children to see allergists because you become armed with information. So, the first thing is, we can sort of figure out their phenotype. And what is a phenotype? It's like sort of the clinical picture of that child. Are they allergic or not? Right? So
Right.
are these symptoms really from allergies or is something else going on? Is there something
Right.
anatomical? Is it their adenoids? Is it their tonsils? Right? Are they, having trouble sleeping because of those? There's like so many different reasons. But so that's number one. Are they allergic or not? And then if they
Right.
are allergic, we do want to know what they're allergic to. If it is an oak tree or trees, grasses, or weeds, then you're right. It is hard. They can't live in a bubble. They're going to go outside. They're going to play soccer and all the other things and be exposed. But at least they know, and there are some things they can do. Don't wear your shoes inside after being outside. Wash your hair if you've been in the park for a while. Don't throw your clothes on your bed because pollen's really sticky. There's so many different things.
Right.
And then we can talk about possible treatment, right? So there's avoidance. There's medications. And so, yes, you go back to doing some of the preventative or, therapeutic medications like antihistamines, nasal sprays, all these different things, which we can get more into. And then there's immunotherapy. And immunotherapy is a form of desensitization to environmental allergens. So again, tricking the immune system into thinking it's not allergic. And, now we have sublingual immunotherapy. So those drops that kids can put under their tongue. And so if some parents are concerned about allergy shots at a young age, so they can talk to their allergist about potentially doing those. But we also start allergy shots as young as like 5 years of age. And there are a lot of 5-year-old kiddos that can tolerate it. The needles are tiny. They're really not painful. And so immunotherapy can be very beneficial depending on the child. It could potentially prevent, severe asthma from developing. So it can be preventative as well as therapeutic. So
Those are some definite good reasons. Absolutely.
yes, so go see
Absolutely.
your allergist. Refer to your allergist.
Absolutely.
And the way we evaluate it is with skin testing. And so a lot of parents don't know. They think you can just get a blood test and, figure it out. Or some are nervous about blood tests. But skin testing is actually pretty benign, right?
And what age can you start doing skin testing? Because, obviously like a 6-month-old, it's hard to do it and have them sit still. What age will you see a kid for skin testing?
There's no cutoff. I mean, I skin test infants as young as 3 to 4 months if we're concerned about a food allergy. We never do environmental testing that young, but we can skin prick them that young. For environmentals, generally we wait at least until 15 months of age or older unless we're really concerned about an indoor allergen. And yeah, so but there's no cutoff.
No age. Okay.
No, I definitely don't. A lot of my colleagues don't have any cutoffs.
All right, so let's talk about the basic patient, or when I say basic, the most common scenario where a child has environmental allergies. What are some basic things, some basic first steps that parents can do, some actionable advice? I know you mentioned avoidance and you mentioned some treatments, but can we delve into that a little bit more? Like what specific advice should we be telling families?
Sure, absolutely. So after I see a patient and I skin test them if I can, or if they have a blood test. By the way, I brought my skin test device so that I can show you that it's not needles, because a lot of people have never seen this before. They don't know how we skin test. They think, that we give like 100 shots with needles, but it's actually like plastic toothpicks. So, and we press it, we dip it into the different allergens, I call it like pollen water or dust mite water, right? And then we prick it through the skin. So that's what it looks like.
Thank you for the visual. I love it.
Of course. I know that there are people that that can't see us, but I think for those that can, I think it's helpful. So let's say we diagnose them with environmental allergies. So let's start with dust mites, because it's very common in little kiddos, especially those with wheezing or asthma. I can't totally diagnose asthma super early on, but you can clinically diagnose it. So a lot of those kiddos end up having dust mite allergy and or pet or mold. And so with dust mites, there are dust mite precautions. So there you can get dust mite covers or allergen covers on your pillows and your mattress and your box spring. You can get rid of carpet if it's possible. If not, then you can vacuum very frequently. And the reason why it's so important to vacuum carpet or get rid of it and put dust mite covers on and get rid of stuffed animals is because dust mites survive well in warm, humid areas. And inside of a stuffed animal and inside of a pillow and in carpet, it's warm and humid. And so that's why they survive really well.
I always feel bad with that advice, though, especially I tell parents they can pick their favorite lovey or favorite stuffed animal. It feels so.
I know.
It feels so mean, yeah. Unless maybe mean. Just pick their favorite.
I tell them to pick one or two favorites. Right. They can either wash those frequently in hot water in the laundry, or they can even put them in the freezer for a couple days. So if they don't ruin, their favorite lovey in the washer, they can just stick it in the freezer, because dust mites can't survive extremes, extreme hot, extreme cold. Right. So, but yes, I usually say put them in a big plastic container, and then they can play with them at certain times. But having them on their bed when they have a diagnosis of a dust mite allergy is not good. I mean, that's where they're sleeping for 8 to 10 hours, and breathing in, all of that allergen. So it's not helpful.
I think you make a good point that because, if you think about there's 24 hours in a day, and if a child's in their bedroom for 10, 12 hours a day, if we really focus on keeping the bedroom clean, that's, I think, where we'll get our biggest bang for our buck in terms of helping prevent their environmental allergy exposure.
Exactly.
That's a good point.
It can get super overwhelming when you tell a family about all of these control measures. I mean, I would be overwhelmed to just go home and think about all these things I have to do. So
the covers,
yeah, it's so much. So focus on the bedroom first, and baby steps. It doesn't all have to be done by tomorrow. But these are things that we know these things. I mean, I see so many of those young kiddos that we just get rid of the stuffed animals and the carpet, and all of a sudden they're fine. And these are kids that were going to the ER multiple times a year with wheezing episodes. And
it's worth it.
Yeah. So definitely take these to heart. It's important to understand that there are things that you can do in your direct environment that can help.
Yes. I also tell families that every day to take a shower where they include or bath or a shower where they wash their hair, because so many pollen and dust can get trapped into the hair. So it's important to go to bed fully clean with a clean room.
Totally.
Is the advice I usually give.
It's very good advice. I do the same. I've had patients, I had an adult patient who was a soccer coach and was very severely allergic to grass, and she fell asleep in her clothes after reffing or being at a soccer game, and woke up with an asthma attack and hives, and because she was like contacting the pollen.
Sure.
So I mean that's an extreme case, but
Yes.
all these little steps can likely add up to be beneficial for the patient.
Yes. Okay, so those are some things that we can do that don't involve medication. Now, what about in the medication front? What would you recommend a family? Because there's so many options out there. It can be overwhelming.
I
And I
know.
never want to throw the kitchen sink at a family, but what are some good first steps to think about?
Yeah, so I want to go into those. I don't want to forget to mention this though. For pet allergies, my number
Oh,
one
yes.
rule, because I see a lot of parents get a new puppy or new cat, and then they realize the child's allergic. So my number one rule is to keep that pet, if the child's allergic to it, out of their bedroom. So that's
Okay.
number one rule. My other rule to be preventative is if you are going to get a pet, please go and have the child play with that pet multiple times before you bring it home, okay, for more than just like 10 minutes at a time, to
Okay.
make sure that they're okay, because it's a big deal. Once you get it home, that's it, right? You're not going to want to take it away. And then my next piece of advice is if you get it home and there's symptoms and the child is then diagnosed with a dog or cat allergy, there are things that we can do, right? We can do immunotherapy and other things. So
That's good to know.
those are, my important tips about pet allergies. But
And
what
is
are
there such thing? I know I just think this is such an interesting myth that I want to clear up. But is there such a thing as a hypoallergenic dog? Because a lot of people will pick pets saying that they're hypoallergenic, and is there such a thing?
No, not really. I know people hate hearing this, but no, all dogs and cats have allergen, and it's not just in their dander, right? And so the people think about hypoallergenic animals because they don't shed as much. But so yes, maybe they have less dander, coming off and having allergen in the environment, but allergens also in saliva and urine. And so that can cause symptoms as well. And so all pets can be allergenic. And in fact, some of those crossbred dogs can actually be more allergenic because the allergen can become more potent during all
Oh,
that
that's interesting.
crossbreeding. So no, there aren't any hypoallergenic dogs.
No such thing, right? I was so disappointed to learn that because I
know it's
always thought that was a nice
disappointing.
option. And
Yeah.
then just to bring us back to the early exposure idea, I've also read multiple studies that living with dogs, specifically in the first year of life, can prevent allergies, right? So that's some good news here.
Absolutely, that is good news. That is good news. Being born into a household that has a dog can be beneficial in preventing allergies, environmental allergies, asthma. Multiple siblings, being in a house with multiple siblings can do this as well. And
Wow.
so yeah. So this goes all back to that germ theory, that hygiene hypothesis, right? So dogs have a certain microbiome, and they'll change, the patient's microbiome. They'll change sort of, the exposure in the environment, and that will hopefully, if that patient is then developing the right microbiome, they'll be less likely to have allergies. And so it's all related. And now, I didn't mention this before, but when we were talking about the hygiene hypothesis, now we know so much more because we understand how much our own microbiome really forms our health, and like really has an impact on the diseases that we develop.
So a great point about dogs. I love it as a dog lover myself. Who I also had allergies to dogs as a side note, and there was no way I would ever have thought about not having her in our house. So the compromise we made was keeping her out of our bedroom. But
good.
I was happy to deal with some sniffles and congestion at the price of having our wonderful dog. So glad you agree with that advice.
Yes.
Okay. So now let's get back to, so somebody has, they've done things to prevent allergies. They're keeping their bedroom clean, their bodies clean. What are the first medications that you would advise a family to use if they're having a stuffy nose or itchy eyes?
So if you look at the guidelines for allergic rhinitis right now, actually the first line treatment is a nasal corticosteroid spray.
Okay.
And those are now, I'll talk about what that means. So those are now actually all over the counter. And the names that people usually recognize when I say that are the sprays called Flonase or Nasacort or Nasonex, right? So most people have heard of these. And if you haven't, these are steroid sprays. So they're, it's a spray into your nostrils, and there's steroids in there that gets onto the tissue in your nostrils and helps decrease inflammation. And by doing that, it decreases congestion, helps prevent sneezing and runny nose and postnasal drip, and it can even have some effect on eye symptoms.
Nasal rhinitis, just to make sure this is really clear for people listening, nasal means nose, and rhinitis is inflammation of the nasal airway, right? So it benefit from one of these nasal steroids, or worth a trial?
Yes, worth a try.
Yes.
And usually I say to patients, or to parents, to patients, that you have to use them for a certain amount of time. You can't just go pick one of these up, feel stuffy, spray your nose, and then, expect to feel different that night or the next morning. They really need to get in there. They need to decrease any inflammation that's already there, and then hopefully prevent new inflammation. And that can take days. So you have to be on it for at least a week. Whenever I do a trial of these with my families, I say, please, give it to your child for at least 2 weeks every day. But just a few days here and there, unfortunately, really won't have a major effect on symptoms.
I think that's a really helpful tip, because I think a lot of families could get discouraged if they've tried it for a few days and not seen a difference. So you're saying at least once a day for 2 weeks to really see if they're helpful.
Exactly.
Okay.
Yes.
All right.
So, and then after that, or alongside it, or first before a nasal spray, depending on the patient, we have antihistamines. And so we have first generation and second generation. What does that mean? So first generation is Benadryl, right? Everybody knows Benadryl. It's short acting, so it only lasts for like 4 to 6 hours, but it's, it's fast acting. But what's the problem with Benadryl? It can cause really bad drowsiness. And there's studies that show even if you do not feel drowsy from Benadryl, your reaction time is decreased. So what does that mean? If you're driving, or you're playing sports, or you're in school and you have taken Benadryl, then you're not gonna be able to react as quickly to something. So it's just, Benadryl, most allergists don't really like Benadryl. 6 months and under, it's fine, right? Because that's the only antihistamine we'll use 6 months and under. 6 months and over, we do second generation antihistamines. So those are the Zyrtec, Allegra, Claritin, right? So those are the second generation long-acting antihistamines. So they last for 24 hours. They, generally speaking, don't cause drowsiness. Some of them can, but in much, much fewer people than the first generation, like Benadryl. So, and they're safe. They've been studied for many, many years, and they are safe to give in young children.
I think that's a great point to make. So a lot of families feel hesitant to give a medication every day. So you're saying they're safe. Now, what about tolerance? Do kids get used to these medications? I feel like there's side effects to everything. Is there any, what are the side effects? Is there anything parents should be thinking about in terms of giving these medications long terms?
Sure. So whenever I suggest that a parent give this to their child, I always tell them about potential side effects like the drowsiness. In a very small percentage of children, these second generation antihistamines might make them a little bit hyperactive. So that's something else to look out for. Okay, all of this is reversible once you stop the medication.
Great
But
point.
I always, again, want parents to be armed with information, be aware for things to look out for. Otherwise, there's not really any major side effects.
Right.
Of course, any medication can cause an upset tummy or a headache or things like that. So it's possible. But generally, they're safe. They don't really cause side effects. I don't, whenever I'm seeing children especially, but with all my patients, I don't want them on medications unless they're necessary. We want to do minimal amount of medications needed. But sometimes they're necessary, right? And sometimes they are needed daily, maybe during the season, grass season, when, patients' grass, allergies are really bad. So every day.
Then take them more.
Exactly.
And then I think that's a really, and especially in terms of quality of life, I always think about, you only want to give a medication if it's helpful, but in this situation, if it makes a difference and your child's not, sneezing, itching, uncomfortable, it's worth it.
Absolutely. And allergies affect sleep. Allergies themselves cause fatigue. They can cause decreased concentration. They can cause, all of these problems. So when you have trouble sleeping and decreased concentration and an itchy nose all during the day, then yes, it's quality of life, but it's even more than that. It's their development. Children need to sleep, right? Because that's how their brain develops and their bodies, so it's
100%.
much more important than people realize.
Right. No, a good night's sleep sets a child up for a much better day in so many respects. Okay, so and anything else we've left that we should talk about in terms of seasonal allergies medication? So we've talked about the nasal sprays, the antihistamines. Any other medication we should advise for families?
Sure. So there's eye drops also. There's saline, nasal saline spray that can sort of moisturize the nasal passages. There's sinus rinsing, where you kind of use like a neti pot or a squeeze bottle of saline, and it goes up one side and comes out the other and sort of cleans the passages. And some kids will tolerate that.
Right. I get such a mixed review on that. Some kids won't even think about it. There's no way. And some kids love it because I think they realize how much it makes them feel better.
Exactly. No, true. Very true. It can clear out some thick mucus. It can help with all the postnasal drips. So yes, there's all these options, and there's different combinations that are right for each patient. And then if we want to touch on asthma, there's of course medications for asthma like inhalers. There's maintenance inhalers. There's inhalers that we use just sort of as needed if we have symptoms or if we have exercise-induced asthma. So there's all of that.
I think this will be interesting for families to hear about medication allergies, and specifically, I want to talk about penicillin allergies because so many people have penicillin allergies or a penicillin allergic person in their family. Just to educate families about this, tell us, are penicillin allergies genetic? So let's say a parent has a penicillin allergy. Does that mean their child is more likely to have an allergy to penicillin?
No.
No.
The answer is no. Penicillin allergies are not hereditary, right?
Okay.
So
I love hearing this.
Yes.
Especially it's, for those that don't know, penicillin is the basis of so many common antibiotics we use, like amoxicillin. Augmentin has some penicillin in it, the cephalosporin classes. So some of our most common medications used do have penicillin. So I'm glad to hear not genetic.
Not genetic.
We can try them independently. Okay. Now, okay. How many, how do I say this? Is it likely that a child who's labeled with a penicillin allergy, is it always real? In other words, let's say a child gets a rash to penicillin when they're 2 years old. Can they try it again when they're 10 or at a later time in life? Or is this a lifelong allergy?
Oh, such a good question. So it's, penicillin allergy. Man, that's a mouthful. Penicillin allergy. We've learned a lot more about it recently, and we have good ways to, really help figure out if a patient really is truly allergic to penicillin. But we have a lot more data telling us that most patients, if they have a remote history, so if they had either a label of a penicillin allergy, right? They don't know what happened to them when they were younger. Their parents told them or their doctor told them, and they have sort of kept that label with them throughout life. Or if it's been, they were really young and maybe they had a rash and now it's at least 10 years later, most of those kiddos will actually outgrow their penicillin allergy if even it was a true penicillin allergy to begin with. And what we know is studies have been done showing that I think about 10% of the population reports having a penicillin allergy. And it's actually, if you really look at real IgE mediated, so that means real allergy, immediate type hypersensitivity or type 1 hypersensitivity, all these different names that we use for real allergy when we say allergy, right? It means, you take a medication and within seconds to minutes, almost always under 2 hours, you have symptoms like we talked about before: hives, swelling, trouble breathing, nausea, vomiting, diarrhea, lightheadedness, all of the things that go along with it, anaphylaxis or,
right.
Severe reaction, or again, IgE mediated. So
right.
that's the most concerning when we're talking about penicillin. And epinephrine, again, would be the treatment for that. Penicillin and other medications can also cause delayed drug rashes. And those are a little different, but again, avoidance of that medication is sort of how you manage those delayed drug rashes.
Right, right. So
go ahead.
I was going to say that a really common scenario that I see as a pediatrician is we'll prescribe something like amoxicillin for 10 days. And on that 8th day, a child will develop a really, bad rash on their full body, and we'll stop the medication, and then the child will be labeled a penicillin allergy. But truly, that's not a real IgE, as you said, or a real immediate allergy, that a child can safely take that medication in the future and be okay.
Exactly. It's not even a delayed drug rash. I'm talking about different things than that. That's really just either a medication, like a medication rash, or a regular drug rash, or it's not even from the medication itself. It's from the virus.
From the virus, yes.
The child has, right? So,
yes.
A lot of times children have viruses, and then sometimes they'll develop a bacterial infection on top of that, maybe an ear infection or sinus infection on top of it, and then they'll take the antibiotic. But the number one cause of hives actually in kids is viruses.
Right.
Right. And we know that there's multiple different viruses that cause all kinds of funny looking rashes. Right. And so if they're on the antibiotic at the same time, they can be confused as the antibiotic.
Sure.
There's also sort of this like mimicry that our immune system sort of gets confused when it takes the antibiotic and it has an infection, and then you get a rash. And again, that will not stop you from getting that penicillin antibiotic again in the future.
Right.
But there's things we can do. There's a movement in the allergy community to try to delabel people with penicillin allergy, because a lot of them, as we mentioned, are not true allergy, and people can safely take these medications.
Yeah, the New England Journal I think it was last year, I was so surprised by this number. They said that 90% of people labeled as penicillin allergies can actually take penicillin safely in real life.
Yep. It's true. It's shocking, but it's totally true. It's not shocking for us, right? Because as allergists, and I think even you pediatricians, like we've known this for years, but I think to the general population, it is really shocking that most people are not allergic to penicillin, even though everyone thinks everyone is. And just knowing that children taking antibiotics oftentimes will develop these sort of just diffuse red rashes,
full body rashes. Yes,
full body rashes. Oftentimes they're not even itchy, and they just sort of they just self-resolve, and generally that's safe again for those kids to have penicillin. But if there's any question, if it's itchy, if it developed at a different time, if there were any maybe other symptoms associated with it, refer to an allergist. We'll talk to them, get details, decide if they just come in, take amoxicillin in the office, and we watch them, or they come in and get a skin test, a penicillin skin test, which has a really good negative predictive value, meaning If the skin test is negative, it's about 95% to 100% that that patient does not have an IgE-mediated reaction or allergy to penicillin.
Okay. Okay,
There are
good.
things
So,
you can do.
yes, I love this. So I just like giving families hope out there. There's so many people that are labeled with a penicillin allergy, and I think it's just good news to know that they might not actually have one, and they can see an allergist or talk to their pediatrician and find out if they really do.
Exactly. Yes.
Okay, last thing I want to ask you about. This is I don't know what you're going to say. Where do you stand on the 5-second rule? So if my child has a Cheerio that drops on the ground, can they eat it, or should we throw it away? What are your thoughts?
I love it. I am so for the 5-second rule.
All right.
Yeah. I mean, it depends where we are.
Okay. Okay.
In certain public places, then there is no 5-second rule. There's no 1-second rule.
To the trash.
It goes right in the trash. But
Okay.
at home or somewhere else where you sort of trust that there is some level of cleanliness, I'm totally for it. And again, all the way back, full circle, hygiene hypothesis. We want to get exposed to germs. We want, we don't want to make ourselves sick, terribly sick, right? With terrible infections and things like that. But I'm all for it. I mean, my kids know it. We'll get a lot of these, like, when we're eating dinner at the table, or we're outside, eating snacks or things. I'll get a lot of like, "Mommy, is it okay? Dropped right here. Is it okay?" And I'll be like, "Yep, go ahead." So
let me lick it first, and then you can have it. Even better.
Yeah, there you go. Well, that's even better, right? With the the pacifier study, where if mom licks it, then the baby's less likely to develop allergies. Yeah, absolutely. But they know they can ask me. They don't have to just throw it away, because many times I'll say, "Yeah, just eat it. It's fine."
Right.
Yeah.
All right. With that, Dr. Katie Marks-Cogan, it was so much fun to have you. I always love talking to you. I hope I get to see you soon.
I know, I do too. So much fun talking to you too, Jess. I love talking to you too. Thanks for having me on. It was a blast.
My pleasure. And so people want to find you, Clear Allergy in downtown Culver City?
Yes, clear-allergy.com is my website. You can Google me, Downtown Culver City. They can go to the Ready Set Food website and read all about food allergy prevention and Ready Set Food. And I'm happy to help, happy to answer questions. You can find me on Instagram, you can DM if you have any questions. Trying to be cool.
Thank you. You are cool. You're very cool. All right. See, I'll send you a DM later. All right.
Okay.
Thank you so much. Thank you. Okay. Bye.
Bye.